Once again, I'd like to thank the organizing committee. I'd like to thank Dr. Bray, Dr. Walker, kind invitation. It's always a pleasure. And after listening to that excellent talk by Dr. Wilson, it's a tough act to follow. And I appreciate more than ever the varied clientele that pediatric orthopedists have to work with, not just in terms of bone, but in terms of ability to reason, ability to make decisions during that difficult adolescent period. I have some disclosures. As Jennifer mentioned, I'm on some editorial boards. I'm the president of the board of directors of the Journal of Orthopedic and Sports Physical Therapy. One thing that I find to be quite fulfilling and quite challenging at the same time. One thing about the ACL, we've talked about it today as a mechanical strut, and it certainly is. And generally the carpentry, regardless of the specific technique that's used, is successful. We do have variable revision rates and failure rates. But across the board, the one thing we do not have is the electricity restored. We have not hired an electrician. We do not have normal neurosensory function. So we look at it in terms of restoring or preventing further anterior laxity. We want to replace it with dynamic knee stability. And really the acid test of success or not is whether or not they pivot shift. And we don't want to have them pivot shift anymore. So as Dr. Wilson alluded to, there's a variety of surgical procedures, including no surgery. I agree with him wholeheartedly about the likely need for surgery at some point. But the surgery now can vary from a primary repair to different reconstruction options. I've done a small series with Dr. David Caborn of primary repairs using internal bracing, and at 3 years in an adolescent population, we've had good outcomes. But there's much more to be determined along this line, and that's an ideal population to consider primary repair and internal bracing, given the open physes and the blood supply and such. So I'll talk about this module. This is something I originally created for the ESCA Society, and specifically we're going to talk about key elements of rehab, post-injury and surgery, the efficacy of programs designed to bridge the gap between surgery, rehab, and return to sports, and in my opinion, strong limitations of patient-reported outcome measures for adolescent athletes. So the tenets of my program, which I've been doing over 10 years now, on Saturdays, we've got a clinic tomorrow with probably 6 or 7 people. I create a healing environment. We try to do no harm, but we push that edge because we need to make sure they're ready to go back to function. We need to educate the patient. We need to develop a tolerance for load, a resilience, an emotional resilience, and confidence, self-efficacy, overcoming the fear that the vast majority have fear. Whether they articulate it as such or not, they have fear. Emphasize exercise movement quality over quantity. And if they don't remember what to do when they're on their own, because I give them things to do during the week as well, I say, leave it out. I'd rather you not do it than do it incorrectly. And we consider biological, biomechanical, and behavioral aspects of healing. Psychological aspects are of equal, if not more importance. So this is just kind of a general table showing by months different things. You'll hear arguments about how soon people should go back to play. These are largely academic, somewhat silly arguments. Definitely longer is better before you release them completely to play. But something we work on well across the recovery timeframe is this concept of neuromuscular control, including once they're released. They still have homework to do. It's not like, even when you graduate medical school, you have CEUs or CMEs that you need to do each year to stay contemporary. And I'm of the opinion that since the ACL is a neurosensory structure and we have not restored neurosensory function, the individual, as long as they want to stay athletically active, they need to do CMEs, if you will, to make sure that their neuromuscular control is prepared to do the sporting activities that they would like to do. So the progression that I do, this is post-PT now. So they've already done conventional PT, which I think is limited in what it can do, largely by the business model that it functions under with insurance and limited insurance business. So they come in on Saturday to me, I get to yell at the children. They come in, and the first session they learn basic movements. The second session we add load. The third session we begin some light two-legged plyometrics. The fourth session we usually go to one leg and see how they can do on the surgical versus the non-surgical side. The fifth session we start adding agility movements. And then sessions 6 through 8 we work on weak points, whatever they might be, prior to testing. So usually over about a 2-month period, I see them and we eventually test them and return them to unrestricted sports activities. So the guided sessions with me, they come in, we work on range of motion, largely of the hip as well as the knee. The hip is key to the knee. The hip's a ball and socket joint, largest, most powerful muscles of the body function across the hip. You want the hip to be your friend. If the hip is your friend in terms of range of motion and strength, you have a much greater likelihood of success in rehabilitation. We work on functional movement patterns, agility, sprinting movements, and we're concerned about metabolic energy systems. By and large, the kids I see after PT, they might look good functionally for 1 repetition or 2 repetitions. Anything more than that, they're thrown up into the wastebasket because they have no load tolerance. Why would they? How could they in the classic clinical environment with only a few visits done early post-surgery? So this is kind of a halfway house before we release them to the chaotic world of organized athletics and coaching. So we focus on reestablishing normal knee extension first. That's always the most important thing following surgery. If you don't, in my opinion, if you don't get normal extension back within the first 7 to 10 days, you're going to have issue with that. So I do see the occasional problems with that post-PT where they never got extension back. Sometimes it's related to graft placement, but more often than not, it's related to prolonged inhibition and not enough attention given to getting that extension. That's my big red flag. Get that extension back. Perform gradual knee flexion. I like to get the heel to the butt in prone with the hip extended. That it takes the slack out of rectus femoris and iliopsoas so that you can really create the real estate that you need, so to speak, so that you can develop it into the neuromuscular function you need. You have to have the range to develop the range. Sometimes we have to delay that if there's a posterior meniscal horn repair, then we'll slow that down a little bit. But ultimately, we get there. It's very important to reestablish that. It will help avoid any type of patellar tendon conditions, any type of patellofemoral compression conditions. By getting that range back, you're going to make the front of the knee much happier, particularly if you use a BPTB graft or a quadriceps tendon graft. And when you start doing it functionally, it's good because when you start actively bringing the heel to the butt, you're restoring some of that hamstring function that you normally don't get back, particularly when you use a hamstring graft, that high hamstring range of motion. So these are examples of some stretches. As you see, they have a knee element to them, but they all have a hip element to them, whether it's the heel to butt or kind of a classic piriformis stretch on one side, modified Thomas stretch on the other side, or something done with loading in the frontal plane to stretch the groin. So we like to emphasize slow, controlled, high-quality movements. We like the frontal plane and the sagittal plane to be able to kind of work together, the musculature to work together. The glutes controlling frontal plane, sagittal plane hip, the quads and hamstrings controlling sagittal plane knee, kind of getting them to work together functionally at slow speeds first before we go faster. Low or no impact. We create the wobble. We make mistakes. We talk about the mistakes. We use these as teachable moments. And this is an ideal time to capture the athlete in regards to the relevance of what these exercises mean to what they do athletically. Some examples: a form run simulation, a back step butt kick, this lateral step, weight shift, rotate, big on multiplanar movements. In the clinic I have any Saturday at the end of my talk, you'll have my email. Feel free to reach out to me, and none of this is trade secrets. You're welcome to come to any clinic or to have me come to your place and do some things. I welcome that, and I always get my students involved at Spalding. I have a few students there every Saturday. So I mentioned restoring knee extension, and by that I mean restoring quadriceps function, particularly true with BPTB and quadriceps tendon graft harvest because you have direct morbidity from graft harvest. But then you need to restore high knee flexion function. And this is true, as I said earlier, not just to decrease the contracture in the front where the graft was harvested, had it been BPTB or quad tendon, but to restore the function of the hamstring if they had used a hamstring tendon graft. So this is of value regardless of the graft that's used. So we increase the strength of the hip and the knee. The hip is impaired following an ACL injury, just like the knee is. Don't think for a moment that this is an isolated injury. This involves the whole extensor mechanism. So we want to improve dynamic mid-range knee stability, and we get back to some basic strength training too. I like to use the single leg press. But here are some examples. We don't do a lot of straight leg raises in my clinic. That's largely something that should have been done in PT. But if we have to correct some things with that, we will, with progressive resistance. More often than not, item B here, the single leg press, we make great use of that. Early on, progressing toward body weight for 8 repetitions. I like an 8 repetition maximum. If we go much less than that at a higher load, I think the chances of injury go up. And if we go higher rep than that, we're not really getting strength. Now, I do make allowances for the total load used based on the situation with the growth plate, and we don't make the total resistance quite as mandated if we have someone who obviously has an open growth plate. But we try to get an assessment, usually using body weight as a rule of thumb for what the strength goal should be. And this can be very telling to the athlete when they find out that they can only push 40% with their surgical side that they can do with their other side. This is eye-opening for them, and it's an insurance policy for me as a clinician to know that baseline strength needs to be restored. Once that's restored, I feel more confident in implementing more aggressive plyometric activities. So the athletic ready position is an important position that we continually go back to with slow speed movements and eventually to higher speed plyometric activities where we have impact loading. Here's some examples. We do a lot of multiplanar lunge movements. We progress to a weighted vest. We use unstable surfaces. Depending on the needs of the athlete, the sport played, the position played within that sport, the role the athlete plays on the team, we try to individualize that to the individual athlete. We move to plyometrics, the power activities. We look for symmetry. We look for smoothness. Words are very important. And, you're hearing this during our presidential town halls and things. People try to catch people saying certain words. And as clinicians, we have to be careful of the words we use too. I don't like to say good leg, bad leg. I like to say surgical, non-surgical. And the kid has heard many times if they've had something that resembled an ACL injury, did you feel a pop? Well, the word itself is not damaging, so I try to use the word pop in a good context. I really want you to pop that jump. I really want you to give it to me, And this helps overcome the fear, and we don't put that kind of boogeyman in the back of their head that something's still wrong here. So we do a variety of hopping. Kangaroo hopping is a vertical hop. It's more for straight ahead power. Frog hopping, it's a horizontal hop, power and distance, really works the extensors of the hip. We do bounding activities, and we progress from 2 legs to 1 leg. And they have to be ready when they go to 1 leg to show me symmetry and smoothness. So with agility training, which we throw in about the 5th session, we go from slow to fast, small to large amplitude, more exploratory to more performatory. This is direct out of textbooks, out of IU actually, with motor learning. I forget the lady's name, but just a brilliant, I think, physical educator in regards to motor learning. Esther Thielen was her name. I took a lot of my ideas from her in regards to motor learning training. From planned activities, highly choreographed to highly unchoreographed. The coaches aren't going to tell you what's next. I'm not going to tell you what's next. But we're always looking for quality technique. So they also do once a week independent sessions. I call the 2 exercises my meat and potatoes of the program, single leg lateral step up and the lateral scissor plank. You get predominantly sagittal, predominantly frontal motion, strength. Sagittal at the hip and knee and ankle, frontal with the lateral scissor plank at the hip. Both of them involve the core. We incorporate the core into almost anything we can do. That's a good idea, particularly with adolescents and particularly with young ladies who tend to have longer impairment or less strength in the core, particularly as they hit their growth spurt. That's been demonstrated by Tim Hewitt in studies at Boone County High School, that the core becomes a big difference between boys and girls once they hit puberty. So this is called the circuit drill. It's one of our agility movements. We also have ones called short ball tall. So I can shout out monosymbolic words at people very quickly, so they have to do directional change movements. And sometimes if they're a defensive end or a linebacker or a soccer player, we do pole cutting out at Seneca Park. I use Seneca Park as one of my primary training sites. We create puzzles. We have the eyes closed. The young lady you see on the left is a lacrosse player from collegiate high school. When her eyes are closed, she just looks like she's completely out of control. You take vision away, you can increase the challenge without increasing impact. So I'm increasing the loading challenge without taking a risk of hurting the graft or creating further injury. Sport-specific training, we consider the energy systems from the ATP creatine phosphate system, which is going to have to be there for explosive movements, in which case you need about a 3-to-1 rest to work ratio between repetitions, unless you want to use fatigue as a training stimulus, as you might have to do if they're playing for a particular coach who has a high volume, low rest attack. And then getting into glycolysis from 10 seconds, 20 seconds, upwards of 2 minutes, like the midfield in soccer or the backcourt in basketball, or to more purely aerobic activities like you might have with a long distance runner. But you have to rehab the energy system. If you don't have that, you're going to fail, or they're going to get chickened, and they're going to be more likely to articulate problems with their joint or sit there playing around with their knee brace simply because they're tired and they're fatigued. And then many times they lose favor with their team and with their coach just because they feel like they're dogging it. Well, they're not dogging it. They've just never been prepared to get back. When they leave my program, they're prepared to get back. I can assure you of that. Bracing, we're starting to see a trend away from the rigid braces as much. They still have their place, particularly for a down lineman in American football, but for in many other sports, I'm going to a more sheer brace, maybe a hinged knee sleeve. There's a new product called the T25 made by Topical Gear. I am not an owner of this company, or nor am I, do I get rewards from this company, but it's an interesting product that we've done some studies with at Spalding amongst high-risk athletic college young ladies on soccer, basketball, volleyball teams. And we found it to be preferred by these athletes compared to a standard knee sleeve in terms of perceived confidence and in terms of frontal plane knee control when performing hopping tasks. So we're starting to see where there are other options beside the rigid bracing, which costs so much and tends to be a problem in terms of fit and in terms of slowing the athlete down. And you have to get so much constriction with the 4-strap systems that I think you compromise neural and vascular function sometimes. So we're trying to have other avenues available. I like Dr. Wilson's comment about varied tools in the toolbox. I think that's absolutely true. And I think it's very true with rehab too, particularly for adolescents. So return to play decision-making, we test them. They can't have any effusion. If they have effusion in their knee, then all bets are off. They're not ready to be tested. If you have effusion in your knee, your quads are going to be inhibited. So I'm not going to test them. We're not ready to go. I seldom see that once they're in my program because they've already gone through acute care, but you could still have it. We don't want to see any signs of limb favoring. So they do hop tests, and we do 20 meters. The standard clinical test is 6 meters. We do 20 meters. And we record the data. We've been doing this for 10 years now. We do the triple hop for distance, which is a standard clinical test. But that's pretty much the only standard clinical test we use functionally. We use more high-end tests. Here's an example of objective field testing. We have 5 categories: form, dynamic knee stability, lower extremity power, agility or reaction time, and then this category I put down is endurance, speed, or skills. And what that's catered to the athletes. So this happens to be for a basketball player. So if you see, we've got dribble drive and things like that, full court drop step defense, things like that. But we'll have very sport specific skills there. And many times we invite the coach in. Sometimes the coaches help me with it. I've had coaches at Cordian, Indiana, actually bring in 7 athletes on defense, and we were testing a quarterback doing a 7-on-7 offensive drop back, run the pass routes as part of the skill set. So we try to get as prescriptive as we can. And then once they're done, everybody goes through weak point training. I give them homework to do. But you're never done. You're never done learning. They're never done. As long as they want to be an athlete, there's going to be exercises that they should do to maintain neuromuscular control. So we published this recently. Dr. Bray was one of the co-authors. We're quite proud of this. And this was on primary ACL reconstructed people, 150. We did the post-program testing that I'm talking about. And we also got subjective perceived function by the athletes. Now, this is not all adolescent athletes, but they're all pooled together here. But there's quite a few adolescent athletes that made up this data set. And we get perceived function using the Knee Outcome Survey Sports Activity Scale. So we do the testing in those categories I talked about, and then we get the results. Now, these are two of the agility tests that we've added. These come from the NFL. They're used at the combine. The one on your left is the 5-10-5, which is like it's a poor man's 40-yard dash. And it gives us very good indicators about symmetry of motion when they initiate their first movement to the right or their next movement to the left, to see if they have side-by-side symmetry, balanced speed, balanced willingness to explode. And then the same thing with cutting with the NFL-L, that's the one on the right there. And all of these tests have normative data that you can see at any college level and certainly at the NFL Combine. So if you have an adolescent athlete that's looking for something to kind of strive toward, you can hook them, or if they have a hero, you can hook them up with some of the information from those Combine sites. But we see that when we do the objective testing, we're well into the 90% of restoring at least 90% symmetry or more, which is very encouraging. So when we do our results, we see that they improve to about 90% on the subjective surveys from 75% when they entered. However, at the end of the program, when you ask them to re-estimate where they really were when they started, they will tell you they're more like at 50%. And I really think they have a false indication of their readiness when they start the program, because all they've done in PT are straight leg raises, maybe some early functional things, maybe some running, but that's about it. And then they're released. And they think from that, based on not having been challenged, they're ready to go. The first time you challenge them remotely, even in phase 1 of my program, they find out, it's self-evident to them that they're not ready. So at the end of the program, they usually rank themselves as now being normal, where they usually came in as abnormal according to that scale. But here you see where they come in and they score themselves, but then when they re-estimate it after they complete the program, they drop by about 20 points. So I suggest that what they do they come in with an inflated concept of readiness. They get an early indication that they're not ready. And then over the course of the program, I think they develop that perception of truly being ready to perform. And I think that's the essence of the value of my program. So not only this, we go back and follow up with them about their perception of being able to return to their sport, but not just return, but return at the same performance level as before their injury. And we have a high percentage of that, higher than reports in the literature currently. And I think I'm proud of that, but I'm not so sure how valid that is either, because this is still their perception. So by about almost 7 years, 6.8 years post-surgery, we had 10 subjects get re-injured. And those rates, we had, these were non-contact injuries predominantly. We had a 2.7 non-contact at the contralateral extremity, not the surgical extremity. So that gets into the bilaterality of an ACL injury. And are we doing enough? We certainly train both sides in my program, but that is a concern. And that's something that all of us, I think, need to look at. So we looked at the characteristics more. There was a difference between those who got injured again and those that did not. The ones who got injured again more tended to have the highest improvement in their perceived function score globally, but they tended to be younger. They tended to have predominantly BPTB grafts or quad tendon grafts, but that's because this includes contact too. And there was a selection bias where these grafts were predominantly given to people, to patients who were going to play American football. So they had a greater likelihood of having a collision contact injury, but they also tended to have more meniscus or collateral ligament injury. So in general, the higher re-injury risk was with the younger ones. I think 17 on average compared to 20 plus. They had the best improvement, which, remember now, this is perception. So I'm thinking they're the most motivated to get back, right? So maybe they're in a hurry. And then greater BPTB quad tendon autograft use, American football, a higher percentage of partial meniscectomy or meniscal repair at the time of the index ACL reconstruction, and then a higher percentage of concomitant collateral ligament injury, predominantly MCL. So I would tell you who use soft tissue grafts, whether it's hamstring, which is an obvious problem if you're taking semi-T and gracilis, but even if you're taking quad tendon, the status of that medial collateral ligament is very important. If you have laxity there and you're just going to let it heal naturally, yeah, it will heal, but the laxity is still there. So you're going to have a greater likelihood of having preferential loading on your ACL graft if the mechanics of landing are not correct. So you have to be very careful on bringing these people along, and you might want to consider some type of hinged knee sleeve to kind of protect that laxity at the MCL. Now, I've said all this, and I know I've gone just a little bit over, but I said all this to get to this. This is the part I couldn't get into the paper that Jennifer and I just had published because we didn't have enough room for it. So this is going into the next paper. This is something I dug out of the literature. This is the teenager's brain, right? I have a 12-year-old, believe it or not, so I'm learning these things in real time. The sports identity and the adolescent, right? So sports participation identity foreclosure, kind of getting away from identifying yourself solely as an athlete, tends to occur during late adolescence in healthy people as a broader range of academic, social, cognitive, motivational, and emotional affective factors and interests develop. This is good. This is called growing up. By avoiding sole identification as an athlete, individuals with more complex self-identities more effectively manage life and sports stresses and mediate successes and failures. Now, to ease this transition away from competitive sports and its potential negative effects on self-esteem, Lilly reported that many college athletes proactively reduced their athletic identities prior to discontinuing competitive sports. Well, it makes sense, right? They're in college, they're starting to think about a career. Maybe they've decided that, you know what, I want to be a physical therapist, or I want to go to medical school. Well, these interests are starting to kind of take on a competing role with athletics, and they realize they're not going to play in the NBA, right? They're not going to play in the NHL or what have you. So over the first 2 years post-ACL reconstruction, Brewer, and I highly encourage you guys as pediatric orthopedists to read Britta Brewer's work. It's exceptional. She's a sports psychologist. Over the first 2 years post-ACL reconstruction, Brewer reported that many patients gradually decreased their athletic role identification, with the largest decrease at the 6 to 12-month post-surgery return to sport decision-making period. So isn't this interesting? They're getting ready to go to sport. They're getting ready to go back. They're getting ready to go back to the sport that they love. This is the same time they tend to start thinking about doing something else and maybe having other roles in their life. So maybe what's happening with some of this is there's an acceleration that, you know what? Maybe your athletic days, at least in the context of which you place it right now, maybe those days are coming to an end. It doesn't mean you can't be an athlete forever or what you're going to do, but they're starting to think about these things differently. So the combination of extremely limited recent sports task experience, high athletic self-identity, and obsessive sports passion in the rehabilitating adolescent athlete may contribute to many being released back to unrestricted sports participation too soon. For these reasons, patient-reported outcome surveys regarding perceived return to sports readiness administered during or immediately after standard physical therapy may not be accurate given the lack of understanding and the emotive state of the adolescent athlete. Remember, they've only identified themselves by being an athlete. Their decision-making in regards to their perception is going to be inflated about because they have such a passion for getting back to what they do. So in summary, we need to correct or minimize the influence of associated impairments. It's not just the knee. And I would suggest the hip needs lots of attention, both range of motion first and then neuromuscular control and strength after. Develop an active neuromuscular control learning environment using social cognitive theory principles. This is a concept by Alberto Bandura from Stanford University. I've been using it for years. It's essentially coaching, vicarious learning by having small group activities and by verbal reward, and by acknowledging mistakes and using them as teachable moments. Your clinicians need to become rehab Sherpas, guiding the athlete through cognitive appraisals, emotional and behavioral responses, in addition to neuromusculoskeletal functional recovery. Combined perceived function assessments with evidence-based, objective, clinical, and field testing. The field testing needs to be relevant. It needs to be similar. We test the basketball players are tested on basketball court with that shoe on. football players on the grass or on the artificial turf, depending on where they play, but with the shoe that they're going to be wearing. We need to continue to improve criterion-based assessments, particularly emotional psychobehavioral assessments. And we need to provide homework to the client and then to update it regularly for them. So in conclusion, this is a supplementation of primary ACL reconstruction and standard physical therapy. We found that it improved patient outcomes and it decreased ipsilateral knee re-injury and contralateral knee injury rates compared to anything in the literature currently. So in addition to physiological benefits, this return to play bridge program provided athletes with more time to reflect about their true sport readiness, self-identity, and their true passions for the sport. Limited recent sports task experiences, high athletic self-identity, and obsessive sports passion may contribute to many athletes being released back to unrestricted sports participation too soon. So thank you very much.